Dr. Peters here with OMNE Chiropractic. We're going to be going through a little presentation I put together. I've done this a few times at local running stores that's titled Knee Pain in the Running Athlete. This is a Loom presentation. It's my first time doing it, but I figured this was a really great way to kind of reach a lot of people and to provide some information that could potentially be really beneficial for runners. Let me pop in here. We're actually going to go here. There we go. So, knee pain in the running athlete. I am a chiropractor and owner at OMNE Chiropractic, located inside of Omaha Spine and Sport. We're located at 156th and Pacific. A little bit more information at the end of the presentation in case you need to get a hold of me or if you have any questions. So, moving right in. A little bit about me. Originally from Glenwood, Iowa. I did 2 years at Doane College before transferring to Creighton University, as you can see here. I was on the men's soccer team. After that, I went to Palmer College of Chiropractic to get my chiropractic degree. Did some training at the Central Iowa VA. I was an associate doctor at Omaha Spine and Sport, and in November of 17, I opened up or started my own business, and I currently operate out of Omaha Spine and Sport. I have had the pleasure of working with my alma mater, Creighton University Athletics. So I go down there once a week and treat all the different athletes that the athletic trainers need a little bit of help on, need some joint manipulation. That's kind of what I do. My sports chiropractic curriculum is over here. We just have additional training in things like Motion Palpation Institute, McKenzie Method, myofascial release techniques. I do dry needling, and then dynamic neuromuscular stabilization is kind of what guides our rehab principles. Painful knees are an epidemic in the running community, with nearly 25% of runners developing knee pain annually. It's definitely the most common thing that I see in the clinic in my running population. We'll get into that later as to why that might be. But if you look here, here's a study out of the British Journal of Sports Medicine. Overwhelmingly, we kind of have this huge chunk of the pie here. Knee pain for injury location is 42%. The next biggest is kind of this foot and ankle, which was where plantar fasciitis would fall into. So I have a presentation on that. Maybe we'll do that later. The best way to think about it is the knee is the middle child of the lower extremity. So we kind of have dysfunction on both sides. This is a family picture. I have an older brother and a younger sister, so I think it fits pretty nicely with this whole middle child analogy. A lot of times we have to address the hip and we have to address the foot and ankle when we're treating knee pain. And that's where most oftentimes the dysfunction lies. Generally speaking, the knee is just a sagittal plane joint. For the most part, it's just kind of flexes and extends. If you look at this is kind of a really interesting diagram, kind of taking into consideration what's called the kinetic chain, and basically that just means the hip bone's connected to the knee bone's connected to the leg bone. So basically we have to respect the kinetic chain when we're treating patients. And a little activity I like to do to think about how important this is if you kind of sitting there in a chair watching this, if you focus on flattening the arch of your right foot, like kind of letting your foot go towards the ground, naturally what happens is that knee begins to track medially, and that kind of emphasizes just the foot bone is connected to the knee bone, and that's why ankle eversion, it kind of causes this dynamic valgus, and if we do this repetitively throughout our running, we get a lot of problems like patellofemoral pain, IT band syndrome, stuff we'll get into later. So the wild card in foot pronation may lie in control of the femur. So what happens down here at the foot might actually, the problem might be all the way up here in these glutes. Knee pain, what it's not. Up to 85% of adults show knee arthritis on plain film x-ray and have no actual knee pain, meaning you are much more than your image. There's a little correlation between the degree of arthritis and actual pain. If they put healthy professional basketball players through knee MRIs, over 40% of them have degeneration in the cartilage, and there's no difference in composition of the patellofemoral cartilage between patients with and without patellofemoral pain syndrome. That kind of leads us to this: functional, not structural. So structural would be the MRIs and the x-rays may show one thing. Functional is how do you squat, how do you lunge, how are you able to repetitively perform a sagittal plane activity such as running. 5 most common injuries. Patellofemoral pain syndrome, IT band syndrome are the top 2 running injuries. Then we get into plantar fasciitis, tibial stress syndrome, which are shin splints, and then knee meniscal injuries. The knee meniscal injuries are more likely than not degenerative. When would that be very important? If there's mechanical symptoms such as locking, popping, or clicking, that's when you should probably go see a knee ortho. But otherwise, most commonly, patellofemoral pain syndrome and IT band syndrome are what runners present with. So what is patellofemoral pain syndrome? The patella is actually the largest sesamoid bone in the body, and it improves the mechanical efficiency of the knee by as much as 50%. So it's not just this bone which you actually can't see in this picture. This is an immature patient. You can't see the patella. What we previously thought is that it was a patellar tracking issue, and that kind of led us down this road of isolation training of this vastus medialis. We tried to, the idea was that the patella kind of moves laterally, so it's clearly must be weakness in the VMO, which is this muscle on this side. So we kind of do these goofy little exercises where you kind of push your knee down, focus on toeing in, and really trying to strengthen up now. As we've kind of learned more and studied this more, we've learned that training in isolation is really, really difficult at muscles, so that we kind of have a little bit different techniques. And it may not be necessarily this VMO weakness. It could potentially be more like control issues here at the hip. So this is what we know now. Dynamic MRI actually showed during a closed chain knee flexion activity that the lateral patellar displacement, which we previous thought, right, the patella goes this way, was actually the shifting of the femur into the patella. So that's kind of interesting. That kind of puts us down that what we do now, which is more proximal hip stabilization. What is this joint? It's the joint between the patella and the femur. So if you think about this, if this was your knee, it's being able to ride in that groove appropriately. So here's the femur, here's the tibia, patella kind of goes back and forth over this depending on the amount of knee flexion or extension that we have. What are some potential causes? So maybe it's not VMO weakness, but what could it be instead? It could be inflexibility of the quadricep muscle. We can easily detect that with a modified Thomas test. That's kind of a no-brainer. We might have femoral anteversion or glute weakness. Those aren't mutually exclusive. A lot of times femoral anteversion just means we have excessive internal rotation at the hip. It kind of makes the glutes at a mechanical disadvantage. So something to think about there, just how you present with your rotation. Femoral anteversion is much more likely to happen in the female population. Generally speaking, we see excessive frontal plane knee motion, meaning it kind of goes outside of that sagittal plane. If you think back to the kinetic chain picture, the knee actually may be diving in because we have a lack of frontal plane control, meaning we're not able to keep that knee in the sagittal plane. Also back to that, it could be excessive pronation. So if we think about maybe the foot is collapsing too quickly and we're not able to control the lower leg, that kind of brings the knee with it. So that's how excessive pronation or the overly flat feet may be causing patellofemoral pain syndrome. What the research shows is that these patients actually have less hip abductor strength. That's the ability to go out with your legs. And they also have less external rotation strength. So that kind of cues us in on the proximal hip rehabilitation for these patients. This study kind of looked at runners with weak hip abductors have much greater range of motion of the femur internal rotation, which leads to greater fatigue. And then we have diminished hip muscle function, thus resulting in a valgus position of the knee, which has significantly or consistently been shown to be predictive of patellofemoral joint pain. What does our treatment involve? So kind of, I've alluded to it already, it's proximal rehabilitation, aka hip strengthening. We have to allow the gluteal muscles to function as the primary drivetrain, reducing the load on further muscles down the chain. Now what does that mean? Ultimately, gets into this red lingo here, big muscles deserve big jobs. Your muscles of your hip, and specifically the glutes, are very large. I mean, we have gluteus maximus, and then the smaller glutes, and they deserve really, really big jobs. So if we're kind of become a knee-dominant runner, then we're overloading the quads, which is going to result in problems because those muscles just aren't quite as big and strong and can't withstand as much, they don't have as much endurance. So what we can do is lumbopelvic manipulation. We can actually change the positioning and the function of the pelvis and the lumbar spine to kind of help provide a greater mechanical advantage, actually increase neural drive to some of the hip and quad muscles. We can dry needle those proximal muscles. If we have like kind of some active trigger points or latent trigger points in there, we can get those muscles functioning a little bit better. We do get into some running retraining in the clinic. Basically, our advice is kind of to be able to move the force around the body by altering stride length, or where you're landing on your foot to kind of reduce the ground reactive forces. So they've kind of showed if you increase your cadence between 5 and 10%, you can actually decrease the load at the knee joint by up to 30. So that's really, really interesting, and has allowed a lot of runners in my clinic to continue to train, continue to run. Taping, we don't do it a ton. We do, it's more of a band-aid before big races. We have kinesio tape here. It kind of just makes the patients more aware of the area to kind of focus on some of the landing mechanics. Orthotics, less commonly a treatment, but if we have patients present with overly flat feet due to genetics, like they actually are developmentally flat, that's kind of a patient that we tend to put in an orthotic to just give them a little bit more support, or even kind of go use some of our shoe experts in town, whether it's Peak Performance or whether it's Fleet Feet, and we're kind of using them to get in a better shoe, maybe a little bit more control. So now we're into IT band syndrome. So patellofemoral pain syndrome is kind of the most common cause of anterior knee pain. Now we're getting to iliotibial band syndrome, which is the most common lateral knee pain cause. So this accounts for somewhere between 8 and 10% of all running injuries, and the main function of the IT band is to provide stability to the knee with foot strike. So if you think about, you kind of look, this is looking at the outside of a leg. You have the tensor fascia lata muscle, which is actually the muscle that ties into this fascial band, the IT band, which goes down and kind of attaches here at the lateral knee. What does not happen is that the IT band does not snap back and forth over the lateral femoral condyle. What we are seeing when we think we're seeing that is actually alternating tensions generated by the glute max and the TFL. So those two muscles kind of tie into the IT band, goes down the lateral leg, and depending on the amount of tension and the knee flexion, can kind of create the illusion that the IT band is snapping back and forth over that lateral knee, which just isn't quite the case. So what this big fancy quote here, which I think is very, very important, because a lot of people are doing this wrong, are treatments aimed at reducing tension in the band are a waste of time. So if you kind of see, or if you yourself foam roll over the IT band, it's just really impossible to change the structure of such a tight fascial band, and you wouldn't really want to. You should really focus on kind of foam rolling closer up here on the hip. So kind of getting into the glutes, the hip external rotators, the muscles that we talked about earlier that are kind of the primary culprits, and what we target in our proximal hip rehabilitation. What the research shows, so this is a very interesting study. 24 long distance runners with IT band syndrome had diminished hip abduction strength in the affected leg compared to the unaffected leg, and when compared to runners without IT band syndrome. The good thing about this is that after 6 weeks of a hip abductor strengthening protocol, that proximal hip rehabilitation, 22 of the 24 runners were pain-free and returned to running. What are some potential causes of IT band syndrome? Downhill running actually predisposes the runner to IT band friction syndrome, which is a kind of a crappy misnomer of a diagnosis. Let's just call it IT band syndrome, because the knee flexion angle at foot strike is reduced. This could potentially lead, or another cause would be overstriding. If we don't land with a slightly flexed knee, which we'll show a picture of it here in a few slides, that it'll lead to overstriding, and that kind of increases the ground reaction forces, increases the forces at the knee. Sprinting and faster running on level ground are less likely to cause or aggravate this IT band syndrome, because, like I said, at foot strike the knee is flexed, and that's where friction occurs. Rigid foot type versus lack of rear foot eversion. So if we have a runner with a very rigid foot type, that's going to kind of allow too much force to go up, right? Like we want nice healthy joints, springy joints to kind of dissipate the forces. So then you will actually see an increase in IT band syndrome in high arch individuals. It's not that it doesn't affect the overpronators, but if you had to choose, you generally see patellofemoral pain a little bit more frequently, at least clinically, in a overly flat foot, and you see a little bit more IT band syndrome in a overly high arch foot. So another cause is this crossover gait. This is when we have weakness in the hip abductors, and we kind of see that femur just kind of continually track too far medially or towards the midline. The development of IT band syndrome appears to be related to increased peak hip adduction and knee internal rotation. Basically, we can't control the midline or internally rotation of the femur, and it tends to compress against the lateral femoral condyle. That's another reason that you don't want to foam roll over this area, because it's a compression injury. We're getting too much compression of the IT band at the lateral femoral condyle or the outside of the knee, and by foam rolling you're actually increasing the compression at that spot. So just a little, one of my favorite movie quotes here, we have Chubbs and Happy Gilmore, not Billy Madison, and it's all in the hips. Here's a little exercise I can kind of demonstrate. This is foundational movement from developmental kinesiology. We are actually activating the proximal hip stabilizers here. We have a shorter lever because it's the knee on the ground. We're to have good pelvic and core control here. So this is an exercise that we kind of do with patients. We also have this one, right? We have the band that is wanting to pull my knee towards the midline or towards the table, and by doing that I can kind of train in this assisted lunge position with the furniture slider. I'm activating this proximal hip musculature, the hip abductors, the glutes, to be able to control and keep this leg in the sagittal plane, to keep my toe and my knee in a line. That's what we want to see. Here's some other ones, right? Like on this one, a little bit more challenging. We're stabilizing. Now we're kind of working this left hip and stance, as well as this one in movement. So we're just kind of performing this little lateral, this hip abduction movement. It's slightly assisted. We have the furniture slider. This is getting a little bit more challenging. We're doing a single leg stance. We're kind of doing this RDL. We're really training this right lower leg, because I'm forcing myself to maintain good lumbopelvic position, let that leg go back, kind of add a kettlebell resistance. You could even add this band on here to make it a little bit more challenging or a little bit more fun. I actually have the same shirt on today that I have in this picture, so good timing. Mobilize the foot. This is kind of the chiropractic approach. Like I said, if you think about the kinetic chain, a lot of times the dysfunction lies in the foot and ankle when we're talking about knee pain. So we see decreased rear foot eversion, meaning our foot is overly rigid, or our joints aren't able to function properly, which is going to kind of, all those forces are just going to go up to the knee and kind of force that knee to address all those forces. And that's just a really poor strategy. There's a nice picture if you kind of look, if you look here. So this is kind of when he's in flight here, both feet are off the ground. If you look at this runner here, we actually see him landing with his knee slightly flexed. This is a good strategy. We're going to be able to absorb forces a little bit more effectively. Notice we're not overstriding. If you see overstride, this leg would likely be straight. So I love this quote: running efficiently is no less of a proficiency than a tennis serve, but it is rarely emphasized in injury prevention, meaning everybody just assumes that they can run effectively. We don't ever really train it outside of perhaps if you're involved in the sport, but if you're just an amateur runner going out there running 5Ks, 10Ks, half marathons, whatever, how often have you actually worked with a running coach or someone to kind of teach you some strategies to be able to do it effectively and injury-free? So here is kind of a classic overstride. Look at the knee angle here, right? Much less bent as composed to here. I mean, obviously we have a very proficient runner. This guy's probably who you're going to see at the local 5Ks, half marathons. So he's overstriding mean. We're kind of excessive heel strike. All those forces are just going straight up to the knee. It's very challenging for this hip musculature. We kind of have the excessive forward lean. Look at his body positioning compared to this one. Kind of a little bit more upright, a little bit more stable. This knee is too far extended. Not that heel striking is bad, because most people do it, whether they think they do or not. But it just, this position is really poor. It's just you're setting yourself up for failure. I don't know if this person has knee pain. I assume if they run long enough or far enough that they would. So something to think about. Most runners naturally select a stride length frequency combination that minimizes metabolic cost. If you want to think about evolution, we had to be able to run far to track prey. So we kind of self-select in a pattern that allows for that. Shifting away from the preferred may be necessary under some circumstances. So we use it a lot to keep runners running, to modify the ground reactive forces and where they are going in the body. We're not decreasing any of the force. Naturally, like, the force is the same because the body weight's the same, the same runner. But we can kind of shift it from maybe a more ankle dominant strategy to a knee dominant strategy and vice versa, depending on presentation. It's better to understride than to overstride. And a lot of times we don't have to make dramatic changes in cadence, which is steps per minute, to have a big impact on where those forces are going. Running form modification summary. So if we increase the step frequency by this 5% rule, so 5% increase in cadence can have an up to 20 to 30% decrease in forces at the knee joint. So what I always tell, focus on shorter, quicker, and lighter steps. Just that idea of being light on your feet. Kind of turn over a little bit faster. It's going to be less likely to overstride. You're going to be more likely to have a mid to forefoot strike. So that is a great way to kind of stay running, to have a little bit healthier. And what I like to think about is it's not one versus the other. It's being able to kind of modify your form to do multiple different things, to be able to run in a more heel strike versus a forefoot strike, and vice versa, depending on fatigue and where you're feeling it. Summary of the causes. Overuse injuries results from a complex training errors, including we have lack of specific strength and flexibility. Maybe we lack hip strength in the hip abductors or the hip the muscles that control femoral internal rotation. Maybe it's a flexibility issue. Maybe we have a quad dominant strategy that's kind of leading to some tightness. Maybe we're training on inappropriate surface or terrain. Maybe we have lower extremity misalignments in our foot and ankle, and then sometimes it is as simple as just updating your footwear appropriately. That's when we use our local running stores. We have a great running community here in Omaha, a lot of resources for them. The causes of all overuse running injuries can be classified as training errors, and thus all overuse running injuries should be preventable. This is a very light at the end of the tunnel, very positive. I think we can have a huge impact. Sometimes people just have different body types that aren't made to run. Hopefully we can kind of figure out with some manipulation, with some exercise, how to optimize that running performance. But this is a very glass half full, and I like to be pretty positive. I think we can prevent a lot of our running injuries with appropriate training as well as exercise outside of running. I love this quote. The secret is there is no secret. The secret is to stop paying attention to anyone who tells you they have a secret. It kind of gets down, this is not just running, this is everything. If you want to get stronger, you have to lift heavy things, rest, and repeat. If you want to get faster, run, rest, repeat. If you want to learn, you have to read, rest, repeat. And I think what this really ties in is the rest part. Too many people just run. All they do is run. They expect to get better at running, which is helpful, but sometimes it's helpful to make sure we get that rest, and with that, make sure we do some of the cross training, some of the exercises, strength and conditioning stuff to give the body a break from one particular activity and get a little bit stronger. What you can do about it. So here's kind of the last slide. Here's my contact information here at the bottom. I would focus on some of the exercises in the presentation. Hip strengthening and dynamic control, being able to control the femur or the upper leg to take stress off of the knee. We have lower extremity joint motion, whether it's ankle dorsiflexion, subtalar eversion, getting a foot that's healthy and can absorb forces. We can also play around with some of the running modifications, whether we increase our cadence 5 to 10% to kind of decrease the load on the knee, as well as training volume management. That's the rest. Working with the coach to progress you slowly in your training is super, super helpful. Our running stores a lot of times do training groups for the various races throughout town, as well as they're great with the footwear. So find a footwear or a shoe that works for you, and once you do, don't try to change it. I always like to say, if it ain't broke, don't fix it. So if you find a shoe that works for you, I would just continue to roll with that one rather than trying to get fancy or trendy with maybe some of the different types of footwear. Adjunct, we have taping on orthotic. So we can tape, we can provide additional support through an orthotic, maybe in a foot, for the foot, and then outside of that, those are kind of what we need to focus on. I'm happy to help, to be a resource to the running community here in Omaha. Here's my contact information, my email, phone number at the office, and then my website. A lot of times we put up different things regarding running injuries and just generalized patient care. So thank you so much for tuning in. This is the knee pain in the running athlete, and I appreciate you watching.